But you can start the session.
Yeah. So, good evening, everyone. On behalf of the Neurotology subsection of the Indian Academy of Neurology, it gives me immense pleasure to welcome you all to our monthly academic webinar. I'm Dr. Vishal Pawar, Chair of Neurotology subsection of Indian Academy of Neurology, and it is a privilege to host today's session. The neurotology subsection was mainly formed with an objective of strengthening academic dialogue in the rapidly evolving field of, vertigo and balance disorders. Our monthly webinars are a key part of this mission, and we are delighted to see such enthusiastic participation in every webinar. This is our fourth webinar, and we are getting participation in every webinar. The neurotology subsection is basically in today's this webinar is titled balance system from the vestibular system to the eyes, and this topic is extremely relevant to all of us involved in the care of patients with dizziness, vertigo, and balance disorder, as it highlights the integration between vestibular inputs and ocular motor control. And we are truly honored today to have with us Professor Renato Cal from Brazil as our distinguished speaker. Professor Renato Cal is board certified otolaryngologist with fellowship training in otology and neurotology from Harvard Medical School. He is currently an associate professor of otolaryngology at Centro Universitário do Pará, Brazil. I hope I pronounced correctly. He is internationally respected for his clinical and academic contributions to vestibular medicine. On a personal note, he has been a great mentor and friend to me and to many neurotologists across the world for his mentorship. And he has also visited India in the past for vertigo workshop. He shares us very strong connections with Indian academic community, and he loves India. I remember learning the concepts of gravity and inertia in BPPV, maybe I think 6 years ago during his webinar during the COVID days. And one of his memorable sentence from that talk was, "Your easiest patient and your most difficult patient can be a patient of BPPV." So, and those insights continue to influence many of us to approach vestibular disorders in our daily practice. And before we begin, just few housekeeping announcements. All participants are requested to keep their microphones muted during the session. Please post your questions in the chat box as the lecture progresses, and the questions will be taken up and answered during the question answer session at the end of the talk. And I would also like to encourage all the attendees to join the neurotology subsection of Indian Academy of Neurology if you are not already a member, to stay updated with our academic activities, webinars, and our future educational programs. Without further delay, it's my honor to invite Professor Renato Cal to deliver today's lecture. Professor Cal, thank you for being with us. The floor is yours.
Thank you so much, Vishar. It's honestly and truly a great pleasure for me to be here, join you guys. I love your country. I have been in India, sadly 10 years ago by now in Kolkata in
Yeah.
Professor um, Biswas meeting, and that was an amazing experience. And you have a lovely country, great food, and most special than that, I could learn a lot about history, about traditions, about religions, and also and a lot of expectations. And they just fulfill my heart with emotions, and it was amazing to be there. And the most impressive thing about Indians, about the Indian, I mean, the country is the people. I mean, you guys are so lovely, so kind, and you treat me in a very nice way. So I learned how to appreciate your people, your country. So thank you so much for having me here. I'm gonna share my screen here. I hope you guys can see that. Let me just.
Yes, your
Can,
screen
can,
is
can you
visible.
see?
Yeah,
Can you see these slides perfectly?
yeah, we can see your slides. The voice is clear. Yeah.
Okay, so we're going to share a kind of experience about how we can use the eyes, I mean, the eye movements to understand a little bit about balance system, including the vestibular system and the cerebellum and the brainstem. So this is the focus of this presentation. This is my hometown. I live in the north of Brazil. My city name is Belém. It's, uh, it's a city in the north of Brazil. It's very close to the Amazon, and we live in a kind of place that we have a lot of buildings and we have a rainforest very close to us. And this is the place where I live. I actually invite anyone to come anytime that you guys are going to be so welcome here. And this is the view of my balcony from my office. I work in 24th floor in a building, in a commercial building. So I see my patients with this kind of view. So I have a few disclosures here. I work as a paid speaker for a few international pharmaceutical companies, and I'm also a consultant of Contronic and Atos and also Interacoustics, and I'm shareholder of GSK in New York. So, and also we have a book, and it has been published by Springer, and it's available worldwide. We have a version in English and another version in German, and you can easily find in Amazon or any online library. So to talk about eye movements, I'm going to start with some recommended reading for all of you guys. Those three books here, I strongly recommended them to go through. The first one is the Neurology of the Eye Movements. I believe everybody knows that. It has been written by Professor Dave Z and John Lee, and this is in the 50th or 60th edition by now. It's a big book, and it's like a Bible of, the eye movements. It's very complete. And I also strongly recommended Professor Agnes Wong's book, the name Eye Movement Disorders. It's not so big book, but you have a lot of great information, a very easy way to learn. And the new one is this book that has been written by Professor David Robinson. David Robinson, he was a bioengineer from Johns Hopkins, and he passed away 10 years by now. And this book has been written by his fellows. They organized everything, and they, kind of did the publication with all his topics and all his information. And this book, it's amazing. I confess that I got this book 1 or 2 years ago. And when I have time, I usually go back to this book, and reading, we always learn a lot of things. So those are my, reference. Those are my recommended reading for everybody. So we're going to talk about equilibrium, right? And I'm going to start asking you a question like, what the equilibrium word means? Like, the word comes from the Latin, right? And means equilibrium or equilibrare. And this word, if we, kind of split the word, we're going to see that "iki" comes from the even, and libraric means swing, which means our equilibrium is trying to keep even our swing. And what is special about our equilibrium is that we can do amazing things with that when we are young, like this Pilates person, or we need that a lot, especially when we are old. So, and we know that our balance system, our balancing decrease over time for different reasons. And we are, our population's living more. So we are dealing with a lot of 8 years old, 9 years old, sometimes 100 years old patients, and they need us. They need us to trying to keep their balance in the best way, trying to avoid falls and fractures and surgeries and ICU and sepsis and occasionally death. So our balance is fundamental to that. And the simplest slide that you're going to see in this presentation is the idea when we ask someone, how do we have our balance? We learn from our, kindergarten teacher that, our balance system comes from three different systems: our vision, our vestibular system, and our proprioceptive. So those different systems, they send information to our brain, especially to the cerebellum and the brainstem, and our central nervous system can interpret those informations and keep us, having our balance, like our gait, our, walking, and our standing still. So, and the first question I'm going to ask you is why do we have labyrinths? And our labyrinths, it's a kind of sensor, right? So, and our labyrinth, it's our sensor. And when we start, just, my dogs are barking around, so I'm sorry for that. So why do we have labyrinths? So our labyrinths, um, when we start asking about our labyrinths, if I ask someone in the street, why do we have a labyrinth? Everybody's going to tell me, well, my labyrinth is for my balance. And this is not a right answer, right? This is not a right answer. And I'm going to tell you why. We learned that we have 5 different senses, our sight, our hearing, our taste, our smelling, and our touch. So those are the 5 senses. And the truly information is that we have a 6th sense. And the 6th sense is the ability of movement detection. And this ability of the movement detections is what comes from our labyrinth. So we can tell that our labyrinth is the responsible for movement detection, for spatial orientation, for image stabilization, and for our balance. So truly, our vestibular system is our 6th sense. Our 6th sense is the ability to, movement detection. So it's not because we see dead people. I don't see dead people, fortunately. But I mean, I have a 6th sense, and the 6th sense is my balance system, inside my skull bones. And when we start thinking about balancing as a sense, change a lot of perspective. Like, and when we comparing those senses, imagine like your vision. Imagine like that you got blind in one ear suddenly, like you have a retina displacement. So you are okay, and all of a sudden you just become blind in one eye, and you run to your ophthalmologist. Hardly the ophthalmologist is going to tell you, okay, do you know what? You have another eye, so it's fine. He will never tell you that. And why he will never tell you that? Because to lose one eye, it's a tragedy. I mean, we have a lot of consequences in our life. I mean, we lose the 3D vision, we lose the visual field. So it's a real tragedy to become blind in one eye. What about our ears? If I get a sudden hearing loss, like a sudden sensory neural hearing loss in one side, and I go for an ENT, the ENT is going to try everything. I mean, he's going to give me steroids and, antiviral and hyperbaric chamber and whatever. They're going to try to recover my hearing. And if I end up not recovering my hearing, they're going to try, I don't know, hearing aids, cochlear implants, and middle ear prostheses, and, all the options for hearing rehabilitation. He will never tell me, do you know what? You have another ear, so it's fine. And when it comes from the labyrinth, imagine someone who have acute vestibular neuritis and just lose your balance function. It's a tragedy. It's like being blind in one eye. It's like being deaf in one ear. And imagine patient with bilateral vestibular loss. It's also a tragedy. It's like to be blind both eyes. And when we start thinking about vestibular system as a sense, it changes the perspective, right? And we never tell a patient, oh, you have an acute unilateral vestibular loss, you're going to compensate. Do you know what? You will never compensate. I mean, even though you get, vestibular rehabilitation and you are getting fine, of course that you're going to miss something because your balance system, your vestibular system is very important. So this is a very good book from a British neurologist, and I copied the introduction here, and he says a sentence that I really like, and he says that it's a very easy to underrate the importance of a sensory system whose receptors are buried deep within the skull and whose performance we are usually not aware. And this could be more true, right? Our balance system is just inside our temporal bone. We cannot see that. Most of people and most of doctors, unfortunately, they are not aware about the vestibular system functioning, and that's our job, trying to make it more clear. So our lab brains, they work on silence. We just don't know that we have them until we lost. And they work synchronically with other systems. And many doctors are unaware about their functioning. I'm going to start with a kind of point of view. Imagine this 6 years old man, he just wake up and he's having a vertigo attack. And this vertigo attack is lasts for a few hours by now. And he got some nausea, vomiting, and heavy sweating. And what's going on? What he's supposed to do? Who he's supposed to looking for? So those questions raise us an idea that who are the owner of these patients? I mean, this patient, they are experiencing vertigo, they got nausea, vomiting, they have no idea what's going on, they don't know what to do, and we have to consider a few variabilities here. So what about his age, his comorbidities, and the availability of medical facilities, the financial resources, and whatever. So there's a lot of questions coming on, and he's supposed to come to a neurologist or otolaryngologist or cardiologist or physical therapist, and he just don't know. I mean, because these patients, they do not have an owner. We know that these patients, they might have a problem regarding to the neurologist field, to the otolaryngology field, to the cardiology, and sometimes the patients, they just end up in the emergency room, right? And our fellow colleagues who are in the emergency room, sometimes they have no idea about the vertigo. I mean, how to treat them, how to deal with those patients. And I can share that to you, especially in Professor David Newman Talker publications. He show us like this paper, and I always highlight this data because I think that's amazing. You know, in the United States, I mean, the whole country, you know, 10% of the strokes, they just miss in the emergency room, 10%, which means in each 10 patients who step in having a stroke, one is sent back to home like with a different diagnosis, 10%, which is not a small amount. It's a very big and representative amount. So when those patients, they have like a motor, you know, kind of symptoms, this number just drops to 4%. What's give us this information? They just show us that everybody knows that if you have some kind of motor symptoms, it might be a stroke. You might call a neurologist. So you don't need to be genius that know if I cannot move the right side of my body, it's probably something's going on, and please call a neurologist to help me out. So this number drops to 4. However, this number increases to 35% when the major symptoms of the stroke is vertigo. And 35% is 1/3, which means if my grandmom goes to our emergency room having a posterior fossa stroke right now, and he's experienced vertigo, he has 1/3 chance to be sent back home with some, you know, disposition of vertigo, disease, vestibular neuritis, or whatever. 1/3 in the United States. And it's huge, right? And another data from Professor Kevin Kerber from the Michigan University and David from the Hopkins, they show us that when we comes for peripheral vestibular pathology, like BPPV, Meniere's, vestibular neuritis, superior canal dehiscence, and whatever, the amount of misdiagnosis in the emergency room goes to 74 to 81%. Pay attention. I'm telling you that if you got a BPPV or a Meniere vertigo attack, you have 81% chance of being misdiagnosed in emergency room. And it does not happen anywhere in medicine. Like if I got an appendicitis and go for an emergency room, probably they're not gonna miss my diagnosis. If I got a heart attack, they're probably not gonna miss my diagnosis. But when it comes to the vertigo, the numbers, the rates of misdiagnosis is just unbelievable. And this is our job. This is your job to solve this equation. And that's our job as medical providers, as teachers, professors, try to spread the word, teach people how to deal with these patients. And how can we do that? This is Professor Raymond van den Berg. He's a very close friend of mine from Netherlands, and he's working hardly in a basic curriculum for vestibular medicine. And this curriculum, it has been proposed by the Barney Society, and it's a big effort trying to, motivate different centers around the world, different universities, trying to provide the medical residents and the medical students, a kind of minimum curricular for understanding more about vestibular medicine. Now it comes to the eyes. And we have a very famous, saying that used to say that the eyes are the windows to the soul. And it's been attributed by William Shakespeare. I'm not sure if the eyes are the window to the soul, but I'm quite sure if the eyes are a very good window for our vestibular system, cerebellum, and brainstem. So our eyes, it's a very good window to study those structures here. And why should I care about eye movements? Why should I be considering, evaluation eye movements in a patient with dizziness? First reasons that eye movements help us a lot to differentiate between peripheral and central condition in a bedside examination. And it's very true. And it gives us a lot of information about the function of the semicircular canals, the otology organs, and also the cerebellum and the brainstem. So many times we can topo diagnosis where the problem is, what is going on, only examining the patient's eyes, right? And we have a lot of structures. And our friend Dan Gold from Hopkins, he's a very good neurologist, and he calls what we call oculomotor machinery. In our oculomotor machinery, we have different structures, especially in the brainstem and cerebellum, and we have structures responsible for the gaze holding commanding, which means those structures who are responsible to keep my gaze out of the primary position, especially the Neuro integrators, the nucleus prepository hypoglossy in the pons and interstitial nucleus of Cajal in the midbrain. And we have some gaze holding structures also in cerebellum, our flocculus and paraflocculus, our tonsils. And we have the Saccades burst neurons, which is PPRF, parapontinous reticular formation, located in pons, and RIMLF, rostral interstitial nucleus of the medial longitudinal fascicle that is located in the midbrains, and also the cerebellum vermis and fastigial nucleus. So those are, the machinery of the oculomotor controls, that we use to move our eyes and to keep control of our eyes. And we're gonna go that in details. I always like to start with these questions here. Why do we move our eyes? Why do we move the eyes? And if you go back to nature, you're gonna see that we have a prey, like this prey. This prey, he has to survive. He has a lot of predators in the nature. So one of the strategies for him to survive is to have like a very big eye field. So this animal, they can see 360 degrees. And the eye field is big, but the accuracy of the vision is not that great. In the other side, you have the predator. And the predator, they have a very narrow eye field, but the accuracy of the vision, it's amazing. So this eagle can be flying, miles away and just see the prey and go get and catch it very precisely, just because the accuracy of the vision, it's amazing. What about us? We are the top of the animal chain, so we're supposed to have like a 360-degree visual field with a very good accuracy. But this is not true. We cannot do that. To do that, we need a brain like this big with a lot of neurons to have this 360 field degree. So we cannot do that. So this is one of the reasons that we move our eyes. We have our retina, but the region in retina we name fovea, and in the fovea is when your vision becomes very, very, very precisely. And we move our eyes trying to put different objects and different targets in our fovea. So my retina gives my visual field, but my fovea gives me the precision. So I move my eyes trying to avoid the images slipping, right, over the retina, and to keep the images steady in a different conditions. So I can keep the image steady even though I move my head. So that's why we move our eyes. And we have different kind of eye movements. We have different strategies to do that. And we have the basically 6 different kinds of eye movements, which is fixation, VOR, vestibular ocular reflex, the saccades, the smooth pursuit, divergency, and the optokinetics. And the only one who is related to the vestibular system is the VOR. All the other ones are related to the central nervous system. And it's very important, especially for ENTs, especially for otolaryngologists who are in training, is try to understand that your only eye movement that's basically vestibular is your VOR. What about the fixation? I mean, fixation is also an eye movement, and because the ability to try to have a targeted fixation in your vision, that you have to, avoid saccades. So you have to cancel, you have to annihilate all the saccades. So that's the reason fixation eye movements is still a kind of eye movement. And of course, to understand eye movement, you have a lot of basic knowledge, which I'm quite sure you guys are the neurologists. I mean, you are the clever guys. I am the ENT. So you guys are the most training persons in the world to know that. And this, trying to understand the eye muscles and the innervation of the eye muscles, we know that the fourth cranial nerve, the trochlear, innerve the superior oblique, and the sixth cranial nerve, the abducens, innerve the lateral rectors, and all the other muscles innervate by the third, the oculomotor. And we have to remember that the nuclei of the oculomotor and trochlear are located in the midbrain, and the abducens are located in pons. And that's a reason for that. Nah? But this is the kind of basic knowledge that you guys knows, but a lot of doctors, they do not know that. And that's very important to understand that. And it's also is important to understand what kind of eye movements when you contract each muscles you have. And now you have to remember that your orbit is in a different angle than your eye bubbles, right? Your eye bubbles in a different angle. So when you contract the superior rectors, your eyes does not go up. Your eyes goes up and out. It's like that, right? So that's the reason when I want to look up, I have to contract the superior rectors, but also the inferior oblique. So that's how I can keep my eyes actually in this vertical position. When we talk about eye movements and eye muscles, and what is the basic difference between eye muscles and skeletal muscles? Like, for example, if I go to the gym, if I go to work out and I lift a lot of weights, after a few, repetitions, I just become saturated. My muscles, my skeletal muscles are very saturated. But does not happen with eye muscles. I never get back home late at night and say, do you know what? I'm so tired because I moved so much my eyes today. I mean, I never experienced that. And you guys probably never experienced that. And we are moving our eyes even when we are sleeping, because this, REM, sleeping phase, we are moving our eyes. So we move our eyes the whole day and they never saturate. It is very different. And the difference between those, we can see that in some disease, like this poor kid here, he has a muscular dystrophy, Duchenne, and we know that all his skeletal muscles are dystrophy, but he can also move his eyes perfectly because the genetic disease does not affect the eyes muscles. So they have, eye muscles, they have rapid contractions. They are very resistant to fatigue. And that's a very explanations for that. They have a different structure difference from the skeletal muscles. They have biochemical difference. Of course, I'm not going to go through that in details, but it's very important for you guys to understand that eye muscles are not the same as the skeletal muscles. And when we're going to evaluate a patient with eye movements, it's very important to make sure if they can actually move their eyes perfectly before do like a vestibular test. In this case, you see that he has a paresis in his right side lateral rectors. So he cannot move the eyes, right eye in a perfect position here. And why it's important to know that? Imagine that I go to perform a head impulse test, a video head impulse test. And I know that his right eye is damaged here, lateral rectors. So when I do the head impulse to the right, to this side, medial rectus is fine. So the VOR gains normal. But when I move to the left, I'm supposed to contract this muscle here, and he cannot do that perfectly. So the VOR gain seems to be down here. So for someone who does not test, I'm also say, well, this patient has a unilateral vestibular loss in the left side. But when you pay attention in this V-hit, you see no saccades here. There's no correction saccades. So if I try another device and just change the position of the camera to the left eye, the VOR gain seems normal. So this is why we have to test ocular motricity before examining the patient. And what about fixation? To keep my eyes in the target position. I know that to keep my eyes there, I need to be able to inhibit all the reflective saccades, right? And that's what gives fovea, keep my eyes on target of interest. And the structure who does that, it's a neuron named omnipulse neuron, and it's located in the raphe nucleus in the pons. And the reason of this neuron is working is because this omnipulse, they just cancel all the reflexive saccades. So that's what makes our eyes steady state. Imagine that my eyes, it's like all the time they want to do saccades in all different directions. And if I want to keep my eyes in that target, I have to cancel that. Then when I cancel those saccades, my eyes can be really focused at. So the omnipulse, they inhibit the burst neurons of saccades, and it's located in the raphe nucleus. Saccades mechanism is very complex. We know that we have the input in our retina, so you have stimulus to the visual cortex, parietal cortex, frontal cortex, some special areas like superior eye field, frontal eye field, supplementary eye field, dorsolateral parietal frontal field. So there's a lot of different structures, and it goes to the reticular formation and then performs the saccades. So what omnipulse neurons does is just cancel the reticular formation burst neurons. So they annihilate the saccades, and we are be able to keep our eyes on targets. And when we talk about eye movements, we use different terms like nystagmus and saccadic intrusions, and many times we are not aware about those terms. And I'm going to start with the nystagmus. What is nystagmus? We have different kinds of nystagmus. We have jerk nystagmus, we have pendular nystagmus, and we have our saccadic intrusions, which is basically the square wave jerks, the ocular flutter, and opsoclonus. So, this is an ocular flutter. What is the difference between ocular flutter and a nystagmus? Why this is not a nystagmus? You can see the eyes are moving in horizontal ways, only fast phase, no slow phase, no interval between the saccades. So this is an ocular flutter, right? Remember, to be a nystagmus, you need at least one slow phase. If you have at least one slow phase, this is a nystagmus, right? Pay attention in this opsoclonus here. The eyes are moving all the way around, and they are performing saccades in different directions, but there's no slow phase. So that's the reason it's not a nystagmus. Now you have what we call square wave jerks. This is very common. This is not a pathological condition. It's very, usually it's very common in old patients, in Parkinson's disease, and different conditions here. Look how the eyes moves around. We have these square waves here. You see the graphics here. The difference between square wave jerks and ocular flutter is because the ocular flutter, there's no interval between the saccades. And the square waves, you have one saccade, an interval, and another saccade. Very quick, but you have an interval. So those are basically the difference between flutter and square wave jerks. Sometimes these square waves might be biphasic or monophasic, right? In this patient, for example, you see that the eyes are then stops and then moves again. It's another example of square wave jerks. Anyone who does video nystagmography studies, you see that all the time. And sometimes it's not a pathological. What about nystagmus? Nystagmus, you need at least one slow phase. And the best representation of nystagmus is someone fall asleep, right? Imagine this girl, she's fallen asleep, and then all of a sudden she corrected that. So you have a slow phase and a fast phase. And what is the pathological phase? Is this slow phase. The slow phase is the pathological. So the fast phase is the correction of nystagmus. And the word nystagmus comes from, drowsiness, dozing off, being asleep. And this is, etymologically where the word nystagmus coming from. And if you want to learn more about nystagmus, I strongly recommend this paper. It has been published a few years ago in the Vestibular Research Journal, and it's a kind of classification by the Barney Society Committee, and with all different kinds of nystagmus. And it's a very good paper. I, strongly recommend that you guys go through that. So this is a jerk nystagmus. It's a nystagmus that you have left beating, which is the direction of the fast phase, which does not make any sense because, we have to remember that the pathological is the slow phase, but we tell the direction of nystagmus the direction of the fast phase, which is not the pathological one. And it's very confusing. I remember sometimes a few years ago, someone tried to change that and try to tell the direction of nystagmus according to the pathological phase, but it's going to be so confusing to change that by now. So we're still using the direction of the fast phase to tell the direction of nystagmus, even though we have to remember that the slow phase is the pathological one. And we have to remember that vestibular nystagmus, it's very suppressed by the visual fixation. So this is one of the important reasons that we should evaluate patients with nystagmus without visual fixation, right? And this is a very good example of pendular nystagmus. And the main difference between pendular nystagmus and jerk is because jerk, you have a slow phase and a fast phase, a slow phase and a fast phase. And in this patient with pendular, you just have slow phase. So you have both sides slow phase, your eyes moving like that. You can see here in the graphic that you don't have that spike. You have like a wave of, both slow phases. This is a pendular nystagmus. This is Professor Miriam Welgapola from Sydney, Australia. He's a very nice friend of mine, and I'm a great fan of her work. And he published a paper years ago, and I always show this paper, and I want to highlight a sentence that I just love that. He says that examining a patient without some means of removing visual fixations, it's like trying to auscultate a heart without a stethoscope. So we need to remove visual fixation if we want to try or study these patients. And to do that, we have different kinds of way to remove visual fixations. You have the simple Fresnel goggles, but you have the very sophisticated video nystagmographies. Of course, the amount of money that you have to spend is different between each device, but the main idea here and the important message here is like you need somehow to remove visual fixation, right? And I'm going to show a couple of examples of why this is important. See this patient here. She got no nystagmus with the eyes open. And when I just shut her eyes, you can see very clear left beating nystagmus with his low face to the right side, which is the pathological one, of course. And the nystagmus beating to the left. And I will never see that if I cannot remove visual fixation. This is another patient. You can see that no nystagmus in the primary position with the eyes open. And when I just shut her eyes, and she has a very strong horizontal torsional nystagmus beating to the left. You see the horizontal component and the vertical component, it's very torsional. So of course the right side is damaged, but I will never see that if I do not have any means to remove visual fixation. And we have to remember that nystagmus might be horizontal, torsional, or sometimes vertical. This is an example of downbeating nystagmus, right? You see no horizontal component here, just vertical components. It's downbeating. This is another patient with downbeating nystagmus. And we know that downbeating nystagmus, you have different explanations. I mean, in a neurological point of view, you have different explanations for downbeating nystagmus, but one of the most, popular ones is the lesion of the cerebellum flocculus. And to understand that, we have to remember that when I move my head down, I stimulate both my anterior semicircular canal. So I have an input, and this stimulus comes to the vestibular nuclei, right? And the vestibular nuclei, you have two pathways, one down to the medulla and medulla, when medulla is stimulated, they inhibit the flocculus, and the flocculus inhibit the vestibular nuclei, so you can modulate the information that comes for your oculomotor nuclei, which is located in the midbrain. So the system is very redundant. So you have a very well-controlled system to try to keep my eyes on target. Now imagine that I have a lesion in my flocculus. So the stimulus comes to the vestibular nuclei, it stimulates the medulla inhibits the flocculus, but the flocculus lesion by a stroke. So the flocculus will not inhibit the vestibular nuclei information. So the information that goes up to the midbrain is very strong. So my eyes go up, and then correct it down. Up, then correct it down. So that's why when we have lesion in cerebellum flocculus, you also experience downbeating nystagmus, right? And what about upbeating nystagmus? It's a different pathways. You know that upbeating nystagmus, you probably have a lesion down in medulla. So the stimulus comes to the vestibular nuclei, go to medulla. Medulla is lesionated by like a Wallenberg syndrome. So medulla will not inhibit the flocculus. So the flocculus will over-inhibit the vestibular nuclei information, does not go up, and the eyes go up, down, and correct up, down, and correct up. So this is one of the explanations for upbeating nystagmus, or the lesion is located up here in the pathways between vestibular nuclei and the midbrain. So those are the explanations for upbeating nystagmus, and at least the most popular explanation for downbeating nystagmus. So when it comes to the visual fixation, we have what we call the old problems, which is the nystagmus and saccadic intrusions, but we have also the new problems, which is gaze holding commands, or the gaze holding nystagmus. And pay attention to this patient here. When she looks to the left, she got a left beating nystagmus, right? And when she looks to the right, she got a right beating nystagmus. And she got no nystagmus in the primary position. So this is what we call gaze evoked nystagmus, right? And this gaze evoked nystagmus, this is another example of gaze evoked. When she looks to the left, she got a nystagmus beating to the left. And when she looks to the right, she got a right beating, with some rebound in the middle. And when she looks to the right, there was right beating. And this is what we call gaze evoked. And to understand gaze evoked, we need to pay attention to two concepts: elasticity and viscosity, and why it happens. Imagine here, I have my eye. So I have my eye in point A, and I want to look to point B, and I want to keep my eyes on point B. So to do these saccades, to point A to point B, you have to remember that you have a viscosity. You have, muscles, blood vessels, you have nerves, you have fats, you have a lot of tissues. So if I want to move my eyes from point A to point B, this force of the saccades might be stronger than the viscosity of the tissue, right? So I perform the saccades and I have a viscosity in the other way. So the saccades are stronger than the viscosity. And to keep my eye in that position for the gaze holding command, you have to remember that we have an elasticity that tries to move my eyes back to the primary position. But I don't want to put my eyes in the primary position. I want to keep my eyes in that position. So this gaze holding might be stronger than the elasticity of the eyes to move back. And the structure who does that is what we call neuro integrator. And we have different neuro integrators for horizontal eye movements and for vertical eye movements. For horizontal eye movements, the neuro integrator is basically NPH, nucleus prepository hypoglossy, which is located in pons, and also the vestibular nuclei with coordinating of the cerebellum. And this concept of the neuro integrator, it has been described by Professor David Robinson in Johns Hopkins. This is a very good picture of Professor, David Robinson, and this little mustache guy behind here is nothing less than David Z. And this David Robinson, he developed the scleral search coin method to study nystagmus, and he includes some math concepts in neurology. So that's how he described the neuro integrator. And this is a very old picture with David Robinson and Professor Z and John Lee when they were fellows, and they were actually learning this, all these concepts in neurotology. What about the vertical and torsional gaze holding command? It's, the neuro integrator is what we call interstitial nucleus of Cajal, that is located up here in the midbrain, and it has been described by a Spanish neurologist named Santiago Ramon y Cajal. And this guy got a Nobel Prize back in 1906. He shared the Nobel Prize with Camilo Golgi, the guy who described the complex of Golgi of the cells. So we see that someone who described this, the vertical neurointegrator, got a Nobel Prize in medicine and physiology. And our brain, they are very good for, motor commands, but they are not very good for, for velocity. They are very good, but they're not very good for positioning. So imagine that I want to put my eyes from point one to point B. Then I have, a Saccade birth neurons who are going to do that. And if I want to keep my eyes on that target, the challenge is to have the positional command. So I have a structure who encode mathematically the number of pulses necessary to keep my eyes in that position. So that's what neurointegrator does. And imagine if I have a problem, my neurointegrator is in horizontal, like cerebellum or NPH in pulse. So my eyes will actually move back, and I say, no, keep my eyes that. So move back, no, go there. No, go there. So I get what I got, the gaze evoked nystagmus. Also, the neurointegrator explain us some concept of the Alexander laws. Imagine this patient. He's not a neurologist patient. He is a otology. He got a vestibular neuritis, few weeks ago. He's probably very well compensated. But when he looks to the right side, he got a nystagmus beating to the right. But when he looks to the left, there's no nystagmus. Look at that. So the nystagmus more increase when he looks to the fast phase of the direction of nystagmus. This is what we call Alexander laws. And the Alexander law, there's a very interesting story behind him. This is the guy, Gustav Alexander. He was an Austrian otolaryngologist, and he described this concept of this nystagmus. And the interesting story is because he's being assassinated by a former patient. He got a patient, and this patient tried to kill him. First time, he went to the jail, and he was in jail for 22 years. And when he was released, he went back and killed the doctor because he blamed the doctor for, a surgical procedure problem that he got an abnormality in his nose, and which is sadly story. But Professor Alexander, he just put his name in the history of the medicine, trying to explain the physiology. Now you see a patient with a spontaneous nystagmus beating to the right, and when, of course, the left side is broke, and when he looks to the right side, which is the direction of the fast phase, the nystagmus increase, and when he looks to the left side, the nystagmus decrease. So this is Alexander law. And what is the explanation for that? The explanation is that imagine that you have a lesion in your left side. So you have a spontaneous nystagmus, slow phase goes to the slow phase going to the left, and the fast phase go to the right. When you are in your acute phase, your neurointegrator just become leak. So when the patient looks to the right side, which is the good side, you have a slow velocity component to the left, and the neurointegrator is leak, so you cannot keep your eyes in that position, so your eyes tends to move back. So you have both forces pushing your eyes to that position, so increases the nystagmus when you look to the good side. And when you lose to the damaged side, you have a slow phase velocity to that side, but the neurointegrator is leak, so your eyes wants to move back. So those opposite directions force, they just annihilate themselves. So that's the reason you decrease the intensity of nystagmus when you look to the pathological side. So this is the physiological explanation for Alexander law. Who wants to learn more about that? There's a very good paper. I recommend you guys to read that. It's a very old paper, but it's very complete. It's like 25 pages only to explain all the physiology of the Alexander's law. VOR, best way to test VOR is the head impulse. Head impulse has been described by Professor Helmag and Courtois 37 years ago in 1988. We are coming to the 38th anniversary. Those are the guys. I'm a great fan. I always, trying to express then how grateful I am for everything he did in medicine field. And the, head impulse is very clear. This is Dr. Tisa van Duren from Netherlands, and he is our model. She has some very good eyes, and she represented what we call a normal head impulse test. So we can move her head in a very rapidly way, and she's be able to keep her eyes on target. What about this patient here? When I move to the left side, oops, there's a correction here. You can see in the slow motion to the left side, there's a correction. In right side, she keeps eye on target. So she got a left side damage. This guy is with right side's damage, very clear. Left side's okay. And this is a bilateral loss patient. She got, a damaged head impulse, both sides. So the head impulse is the best way to evaluate VOR in a bedside explanation. And this is some devices. This device has been developed by a friend of mine, Dr. Karina from Chile. She, developed this device she calls head impulse training device. It's good for medical residents and for medical students to learn how to perform a head impulse. And when you do a good head impulse, you got a real-time green light. And when you do a bad head impulse, you got a red light. So it's a very nice device for training. The clinical head impulse is great, but it does have some limitations here. First limitation is because it's a very subjective test, which means we are not allowed to, you need to understand the test to interpret that. And it's according to different examiners, you have different interpretations. So this is a very subjective test. And it's quite hard to test a vertical canals. You can do that, but it's not so easy. The sensitivity is not that high, especially in chronic phases. Because after the acute phase, the patient got a lot of cover saccades, and these cover saccades, they masquerade the over saccades, and our naked eye cannot see the cover saccades. So the sensitivity of the test decrease a lot in chronic phase. It's very clear in acute phase, but it's not so clear in chronic phase. And it's not a quantitative test. So you do a head impulse, you say, okay, right side's broke, but you don't know how much is broke. You don't know what is the percentage of the vestibular function that is still remaining there. So it's not a quantitative test. And it's hard to record. You can put your iPhone in slow motion and record that, but it's not so easy. So that's the reason we have what we call video head impulse tests. We have different devices for different companies. And for example, in this patient here, if you pay attention, it's not so easy to tell what's going on. The clinical head impulse is confusing. And when you do the V-hit, you see that she has a, left side damage with a lot of cover saccades here. And for example, this patient here, if I ask you to take a guess, which side is broken? It's not easy, right? And when you do the V-hit, you may see that this is a bilateral vestibular loss. So the reason that we need a video head impulse device is because it's more sensitive than clinical head impulse, just because they see the cover saccades. What about the saccades? The eye movement saccades. This term saccade comes from French. When you are hiding a horse, you just move the horse head, and it's a saccades. And we call Saccades, which is a very fast, voluntary or reflexive eye movement with a very high speed. And so we have velocity, accuracy, latency, and conjugancy of the eye movements. But the good things about saccades, Professor David Z used it to tell that saccades is actually a brain tool. What is a brain tool? It's a tool that your brains use to fix problem in other eye movements. Imagine like when you have a problem in your VOR, what are you going to see? A saccade. When you have a problem in your smooth pursuit, you have a flocculus lesion and your smooth pursuit is not working properly. So it becomes saccadic. Now imagine that you have a lot of ways that saccades work in a physiological way, like fast phase of the nystagmus. What is the fast phase of the nystagmus? It's a saccade, right? What is the fast phase of optokinetics? It's a saccade. What is the initiation of smooth pursuit? It's a saccade. When you suppress the VOR, you're performing micro saccades. So the saccade is very important in a physiological way, but also in pathological way. When you got a VOR deficient, you got a saccades. When your Neuro integrator is leak, you got a saccades, like gaze evoking nystagmus. When your smooth pursuit is impaired, you got a saccades. When you have some vestibular cerebellum disability, you got a lot of saccades. So in your downbeat in nystagmus, you have a slow phase and a fast phase. So the fast phase is a saccade. So saccade is the kind of way your brain uses to keep your eyes in target, especially when you have a problem in other eye movements. And you know, the mechanism of saccade is very complex, and I'm not going to go through all the details. You guys are the neurologists, so probably you know better than me all these connections here. And what is important, the message here is that to learn about the saccades and know the mechanism gives a lot of information for the functionality of the neural circuits and pathways. So you can use these pathways to understand better patients with traumatic brain injury, concussions, and also some patients with some neurodegenerative disorders like multiple sclerosis and so forth. Pay attention to this girl here. Look at all the details here. Couple seconds. Your eyes did that. Your eyes just perform a lot of saccades. When you see a painting like that, which is exposing in the Met in New York, pay attention to this painting. Your eyes did something like that. You did hundreds of thousands of saccades in a very rapid way. And the interesting point here is when you perform a saccades, you become blind. I mean, partially blind. When your eyes move to point A to point B, that millisecond, you don't see anything. So you become blind. And we just do not realize that during our day life, during saccades. But imagine that you are driving a car, 300 kilometers an hour, and you are doing saccades all the time, and you become blind in each saccade. So maybe it does make a difference. I'm a great fan of Formula One, and I love to read the papers of Professor Giorgio Guidetti from Italy. He unfortunately passed away a couple years ago from the COVID pandemic. He was struggling against the COVID, but he unfortunately died during the pandemic. And Professor Guidetti, he was one of the most important Italian neuro-ophthalmologists and neurotologists. And he worked for a Ferrari. He works for the Italian Formula One racing team, who training pilots to get a better performance in saccades. So he concluded that professional drivers, they have a better performance when compared to naive drivers. The athletic men and women who had acquired those performance with training, and this, this attentional capacity tends to remain high over time. So if you test your saccades performance with some, retiring Formula One driver, probably they're gonna have a better performance than you. Women generally show lower performance than men, and those are the information that comes for you to understand that your patients, you can test and you can train your patients to perform good saccades. And to make a long story short, I just remember you that for horizontal eye movements, the structures, the most important structures are located down in pons, which is the PPRF, which is the burst horizontal saccades neuron, and the NPH, which is the neurointegrator for horizontal eye movement. And for vertigo eye movements, these structures are located mainly in the midbrain. You have the burst neurons for vertical saccades. It's located in rostral interstitial nucleus. And your neurointegrator for vertical saccades is located also in the interstitial nucleus of Cajal in midbrain. And we got a lot of information about saccades, like this patient. Look how slow is the saccades. He looks to the both sides very slow. So the precision is good, the latency is good, but the velocity is very slow. And this is a normal velocity of saccades. Now take a look in his saccades. He looks to the left, he looks to the right, to the middle, left, very slow, to the right, very slow. And the head impulse was actually normal. So the VOR was normal. So he got a problem in the velocity of the saccades, right? Head impulse is normal. What about the accuracy of the saccades? Look, this patient, he got what we call hypometric. When she looks to the saccades, she does a hypometric and correct. So this is a problem in precision of the saccades. This is a hypermetric saccade. This is a patient when she looks to us, she go all the way and move back. This is a hypermetric saccade. So the summary of this is like when you have a problem in the latency of the saccades, you might have a problem in your frontal lobe, which is a voluntary saccade. It comes from the frontal lobe. When you have a problem in the accuracy, probably in the cerebellum, right? If you have an overshoot, it's a problem in fascial nucleus in cerebellum. If you got an undershoot, it's probably the dorsal verms. If you have a problem in the velocity, it's the burst neurons, PPRF for horizontal, and RI, MLF for vertigos. And the stability of the saccades, you probably have a problem in your neurointegrator or in your omnipulse neurons. When you have omnipulse, you got oculus flutter and opsoclonus, and the opsoclonus is a lot of saccades, right? Smooth pursuit, when you got a problem in your smooth pursuit becomes saccadic. And who control your smooth pursuit is your cerebellum flocculus, right? And also, when you have a problem in your smooth pursuit, you also have a problem in vestibular reflex suppression. The only exception is in canvas syndrome, because the canvas syndrome, they do not have VOR to suppress, right? So this is my talk. This is the take-home messages I want to tell you. First one is that a solid understanding of the eye movement is very fundamental for an accuracy evaluation of these patients. Ocular motor examination remains the most effective tool to differentiate between peripheral and central vestibular disorders. And, the ability of perform a very precise and reliable head impulse test is essential, and it takes time. I mean, you need training to do a head impulse test, not that easy. And the last one is the medical community urgently needs well-trained professionals, just like you guys. You guys are neurologists. You guys have a very big responsibility to teach us, otolaryngology, emergency physicians. We need to learn from you some, neurology perspective point of view. What is the relations between eye movement and cerebellum and vestibular system? And when you do your job, when you teach us to interpret tests, when you do your job teaching the emerging physicians, you're going to save a lot of lives and you're going to do a very good job. So thank you so much. And I have a very last clinical case if you have interest to see that. I know that I am running out of time, so I'm all available for, show the case or answer questions or whatever you want. Thank you so much.
Thank you, Professor Renato Cal, for that amazing talk on vestibular system and role of eye movements. It was amazing to learn from you about various ocular motor pathways. Now, I would like to request the attendees, if there are any questions, I will, Professor Cal will be happy to answer that. So, yeah. You have like presented it in a very simplified way, and it was so
Okay, thank you so much.
yeah.
This is, Vishal, this is our job. I usually tell people that, I am not a neurologist, so I don't have a neurology background. And I know that a lot of things for a neurologist seems very easy. I mean, you guys know the located of the oculomotor nuclei control in midbrain. If you ask a normal doctor, like a clinician or otolaryngologist, they don't know that. And this is important to make hard stuff simple, right? And when we try to explain a head impulse, Alexander Gaze, Alexander Law, and the VOR, the saccades, in a very simple way, people start to understand that. And this is the main reason. And I'm amazed that it's a Friday night in India. I know that we have a lovely morning in Brazil, but you are a Friday night in India, and we have like 76 people here online, which is in a Friday, which is amazing. So thank you so much for joining us. And I think that you should, spread the word. We should, our jobs to teach people.
Yeah, yeah,
And
yeah.
I have a question for you, Vishal. I have a question for you.
Yeah.
Take a guess. Take a guess. When you have like a first year medical residence, You have your first year medical residency. How many head impulse do you think that's necessary for someone to perform a very good one? How many head impulses, how many patients you have to actually do the head impulse to be very reliable? Do you have an idea?
Maybe 100.
250.
Oh,
250. That is a paper published that show us a naive doctor takes 250 patients impulse to get the same level of head impulse of a training neurologist, which
yeah,
means that idea when they start, advocating for hints, the idea that, wow, we're going to put video head impulse in the emergency rooms and the technicians will do the head impulse and we're going to interpret that by distance, it's not going to work. It's never going to work because takes time to training. Head impulse is not so easy.
yeah. Because like I started using the video head impulse, I was doing the clinical head impulse, but as I'm doing video head impulse from last 3 years, I'm still learning because it's a very skillful technique. Every day you learn something, and it's something.
You have a lot of artifacts, and you have to understand the artifacts to do a good interpretation. I'm going to be happy to give a talk about video head impulse anytime. We can schedule that. I have a lot of experience. Unfortunately, I'm doing head impulse by, I don't know, 15
Yeah.
years by now, no, 13 years by now. So it's a quite a while. And the idea about the video hand impulse test change over time. I remember when we started doing that, we pay a lot of attention in VOR gain. And right now we are much more focused in Saccades behavior, which is
Yeah.
gives more information than VOR gain itself.
Yeah. So, meanwhile, there are so many comments which we have received about your excellent talk. And there is one question which, like, I will put to you, which is actually for congenital nystagmus. What is the mechanism of null zone in congenital nystagmus?
I'm going to be very honest here. I have absolutely no idea. And I have absolutely no idea. I'm going to tell you why. I'm not a neurologist, so I don't see a lot
Yeah,
of congenital nystagmus. And I'm going to be happy if you guys can help me out with that because I don't know what is the mechanism of the new plane of the congenital nystagmus.
yeah, yeah. So basically, I would answer that question. In congenital nystagmus, there is one angle where the patient is like the clarity of vision is better, and where the nystagmus is less intense. That is null zone, and that is different in different patients, and especially the patients use different strategies for improving their visual acuity in congenital nystagmus. Either they try to converge their eyes, which also reduces the intensity, or they try to look into the null zone, like which might be different for different patients. And but the mechanism of that, to be honest, even I don't know. Like that is the point where that is the angle degree of angle where they have better vision. So maybe in the forthcoming webinar, I would answer that question in detail. I will go through the literature.
This is probably the very similar mechanism than albinism nystagmus, right?
Yeah, yeah.
They have some point they have a very clear vision, so they try to
Yeah.
keep the eyes in
So
that region with the clear vision.
yeah, yeah. And the current nomenclature for congenital nystagmus is infantile nystagmus, because it is seen in the infancy, and it sometimes it may not be seen. Congenital means from the birth, but it might be apparent later. So the current terminology is infantile. But it was an amazing talk. There are so many comments about your excellent talk. There is one question in cerebellar pathology. VOR and HIT remain normal. Can we rely on head impulse test on this?
Yeah, yeah, that's a very interesting questions because we know that cerebellum has some, importance in the VOR also. But VOR it's a very, the latency of the VOR is very short. It's about like 80 milliseconds. And you go, even though you have some pathways to the cerebellum, but the pathway to the ocular motor control is very, very short. and it actually gives us a lot of information about the vestibular perspective. So you can be quite confident and trust your head impulse. But the issue is, remember that patients with ICA stroke, they have pathological head impulse tests.
Yeah.
So that's the reason you have hints and not only head impulse.
Yeah.
If you do not have this ICA variability, if it's only pica, probably the head impulse will be fine to differentiate. But just because of the ICA, you have to evaluate the nystagmus and do the cover test to make sure the patient does not have skew deviation. But yes, answer your question, yeah, you can actually trust in head impulse.
Um, Okay, great. I think it was well received. There is one more question just now. What you have found in vestibular migraine, like what are your findings of video head impulse test in patients with vestibular migraine? And what are the insights behind that? Like what are the insights which we can gain from that?
Okay, I'm going to share my experience with vestibular migraine in video head impulse. You have no patterns, which means no patterns. There's none finding in video head impulse that you can actually stamp. Okay, this patient has vestibular migraine. What we see in our experience, patients with vestibular migraine, they are very high sensitivity for everything. So the head impulse test is a very comfortable test. I mean, you can do it in your patients, and no one is going to complain that. If someone complain about anything, they probably have vestibular migraine. They are very sensitive when you move your hands. So you have some literature that says that you might have some high VOR gain in some vestibular migraine patients, but it's not very reliable. So the simple answer is no. But I'm going to share one thing that our group in Brazil published last year, which I believe that's very great for vestibular migraine, and I wanted to share with you. There's no biomarkers for vestibular migraine, which means you have a patient with migraine and you're going to go for a physical examining. There's no biomarkers. Sometimes you have downbeating nystagmus, and sometimes you'll find different things, but there's no one finding that you can say, okay, this is vestibular migraine. However, we published a paper about what we call NPC, near point of conversion, which is very interesting. We know that migraineurs, not vestibular migraines only, but migraineurs in general, they have problems in doing convergency. When you put your eyes, the divergency is the only eye movement that your eyes moves disclosure gaze. I mean, when you do saccades, when you do smooth pursuit, they move together. But when you do vergency, they comes from, they move different ways. We know by many years that migraineurs, they have problems in convergency. So this is one of the explanations why they hardly can read when you are in movement. They got motion sickness because you do convergency when you read in car. So they have problems in convergence. So when you put your finger like that, and you just move your fingers close to your nose, and you tell the patient, tell me when the vision becomes blurry. A normal patient, the vision becomes blurry about 10 centimeters of your nose. This is normal patients. Migraineurs, the vision becomes blurry much more than 10 centimeters. And we published that. And it was amazing because we got, I don't know exactly the number, but probably 50 or 6 patients with vestibular migraine. And the statistic was almost 100% of the patients, they have, a high NPC when comparing with normal controls. And this is one of the things that I do in my clinical practice when you have a patient which, with all the aroma of vestibular migraine, they have all the history, they have, dizziness, photophobia, motion sickness, phonophobia, family history of migraine, headache, she's a young lady, and everything. Do the NPC, and you're going to see that the vision becomes blurry in a much higher than 10 centimeters, and it's in almost 100% patients. And another thing that we are testing right now, it's not publishing so far, but we are in trying to publish that, and Asaf Shaking is published with us, is trying to put some vibration in the neck, in a specific point in the neck, and you got nystagmus in more than 70% of the migraineurs, and they just become dizzy. So the NPC and the vibration test in the neck, it's maybe a couple of biomarkers of vestibular migraine.
And even there is a recent study from Professor Guffoni on pupillary hippus in vestibular migraine. Yeah.
Exactly.
So we have one more question. Like, can you throw some light on early acceleration and premature deceleration pattern of eye velocity, that is EAPD, and backup saccades in VHIT?
The what they call the premature, acceleration, early acceleration, and eye movements, probably they are trying to anticipate the movement. They try to anticipate before you actually, when you are performing like a Saccade test in a VNG, you say look left, look right. When they try to anticipate, you get some early movement of the eyes. So when you got this early acceleration, probably it's anticipation. And the deceleration of the movements, it's probably in the accuracy of the saccades. So it's related to the cerebellum, right? And what the other question is, the backup saccades in VHIT.
Yeah.
Backup saccades in VHIT, there's a lot of explanations for that. The most common one is when you do the what they call the bounce. Let me try to explain to you. Imagine here, I'm looking to a target, and I move my head to the right. So my eyes to the left. Now imagine that I move to the right, my eyes go to the left, but I move back here, and the eyes move back here. So when you do your hand pulse like that.
Yeah.
So this is what we call bounce. And this is a mistake. This is a technical error. So when you do the hand pulse, you should do something like that. And stop. Move back and stop. Move back and stop. When you do that, you do the bounce and you have an anti-saccade, right? So this is most common explanation for that.
Yeah, that's a great explanation. So we need to exactly stop at the point where we ended, because if there is little movement again back, there will be another saccade going.
Exactly, because when you go and you move back, the eye is supposed to go the other way. So
Yeah,
that's
yeah,
you go, the eyes come here. Then you move back, the eyes go the other way. So we call an
yeah,
anti-saccade.
yes. And there is another question, like convergence spasm, is it common? Why is it common in vestibular migraine?
I don't know why is it common, but I agree that it is common. But I don't know exactly what is the mechanism and why is it common. But it's true. And those patients, they have problems with convergency. It's they
Yeah.
experience that, and it's very.
Yeah, so there is something like convergence insufficiency, and convergence spasm specifically happens in patients, benign convergence spasm in psychogenic patients. There are certain patients who have excess stress, and during the, because of that, they develop benign convergence spasm. So we see some patients while doing VNG, they converge, there is accommodation reflex activation, and that can happen. Even that can lead to dizziness, like it can cause dizziness. I think that's like that finishes all the questions which were posted. It was amazing talk and amazing discussion. Thank you so much for accepting our invitation, and thank you for everything. Yeah.
Thank you so much, my friend. It's my pleasure. It's my honor. Like I told you before, I love your country. I love the people from India. I have an amazing experience in India when I was there. I will never forget that. I hope I can come back to different
So,
cities.
we will plan
And,
something.
yeah, and I was telling Vishal, I'm gonna go for the Middle East. I mean, we're gonna go for Saudi Arabia in a couple of weeks, and then to Dubai for the Middle East conference. But I'd love to come back to India. It's an amazing place. I have, lovely memories. And thank you so much.
Thank you. Thank you so much. Thank you. Yeah. Okay.